Thank you very much. So welcome back, Bernhard, and it's great to have you here again. This is the second clinical discussion that Bernhard and I have done in relation to the bodily relearning courses that Bernhard has started teaching. So these sessions are designed to give you an insight into the bodily relearning course and how to practically use it in your clinic. It will act as either an introduction if you're interested in doing the full course, or as a standalone piece of session where you, sorry, or as the standalone session, excuse me. So Bernhard has an upcoming 3-day bodily relearning course running in October. And at the end of the session, we will give you some details about that. So if you are interested in joining that, just hang around at the end and Bernhard will talk you through what to expect from that. But just for this session today, we are going to be talking for about 30 minutes. Do you know, I haven't done one of these for about 6 weeks and I've lost my flow a little bit. We'll get there. We'll get there.
We'll get that.
So we're going to be talking for about 30 minutes. If you have any questions, please do drop them in the chat and we'll get to as many of them as we can. And if you want to watch the recording of the session, you can access that on the Noi Group Clinical Discussion YouTube channel. I will drop the link to that into the chat right now. And if you subscribe to that, you'll be notified when new videos are uploaded. So that's quite handy. And today, Bernhard is going to be talking about bioplasticity, the science of how bodies relearn and adapt. And we're going to be talking about what bioplasticity actually is, why understanding it matters clinically for your persistent pain patients, and how to help patients leverage their adaptive capacity in practice. So, question number 1, Bernhard, what is bioplasticity?
Actually, the term bioplasticity, when I heard it the first time, was of course in the Explain Pain and Explain Pain stuff from David and Lorimer, because we have to look a little bit further of the term neuroplasticity, because neuroplasticity is a term everybody is quite aware of. We know this from neurological rehabilitation after stroke and so on, and the research to neuroplasticity is quite old already. And in pain, we were aware that neurons and neural connections also have, of course, a plasticity. So there was a long time the idea that pain might be something learned, but we are much further now than this, that it is a learned situation, which also has to be connected to plasticity, which means adaptation of the nervous system centrally and also peripherally, by the way. But nowadays we are aware that not only neural components have a big contribution to pain and also nociception, but also the immune system. So the immune system, like several immune cells or immune-like cells, we have to call it like that, are able to influence nociception on the one side and also pain on the other side. So we are now aware that learning and adaptation and plasticity is not only a neural component, a neural part, but also an immunological part. And that's why I think David and Lorimer formed the term of bioplasticity. So the pain is something that is also depending on immunological states, immunological work, immune cell activity, actually. I think actually that we can go further than that, because bioplasticity, as we also teach it in our courses at the moment, not where it sounds a little bit apodictic now, but as we try to facilitate our thinking also, is on neural and immunological parts. But I think that bioplasticity could be even extended on other adaptations in our body. Like the last time I was talking about mechanosensitivity of peripheral nerves. Yeah, as you remember, using neurodynamic techniques to assess and also to treat mechanosensitivity. Actually, mechanosensitivity is also something that has bioplasticity as a background. We are also aware that we don't even have to have a pathological state in our body that includes bioplasticity. By example, circadian rhythms, or think about menstruation. This is also bioplasticity. Yeah, there is something changing in our body. And I think it's it's an umbrella term actually thought to include immune cells and the immune system into the understanding of nociception and pain. But actually, I believe that bioplasticity is something that really, really affects us in our bodily, in our psychological, and also in our environmental and behavioral systems.
Mm. Okay, thank you. Fascinating.
Mm.
Why is understanding bioplasticity so important for clinicians, particularly working with persistent pain?
I think it has a direct effect on the understanding of the person. And if we try to understand persons in their situations, they feel, of course, validated, and then they're
Mm,
more open to understand their situation and their influences that might affect their pain situation, their fatigue situation. We're always talking about pain, but there are many other aspects as well. Their psychological states, and to understand this contributions of all the parts. If we think about the biopsychosocial framework, which is also, I think, a very conflicting term in its real real work with the biopsychosocial system. But if we think about all these aspects that affect us as persons, we have to have an understanding of these bioplasticity components. And one of these components is the immunological system. And our immunological system can be influenced by sleep, can be influenced by our work, can be influenced by our activity levels and so on, or metabolic systems. So it makes it a little bit more complex, not complicated, but a
mm,
little bit more complex. And I think this complexity is very important to deliver also to our patients in a validating way with their knowledge they already have or with their
mm,
expectations they have to get this so-called aha moments after education. Yeah, I think this is very important because I did education many years with all this stuff of biopsychosocial framework and mature organism model and so on. But
mm.
I'm not sure if I was able to um, get this idea to every person I've worked with this aha moment so that they can start to change and to adapt with their systems. So I
Yeah.
think this is very profound aspect. Yeah.
Yeah, that's super interesting. So that sort of
Yeah.
brings me on to my next question, which is if bodies are bioplastic and
Yeah.
ever adaptable, why do patients feel stuck or
Yeah.
unable to change? What's going on there?
I think that this feeling stuck or this not going on is actually also a sign of bioplasticity because they didn't always feel that stuck.
Mhm.
So they changed something in a plastic way. And plastic, as you know, maybe this plastiline we have here in Austria, we call it plastiline.
Mhm.
We adapt some kind of forms and it can get hard. Yeah, but before that, there was a plasticity going on. And this is why we have can try to find out where are or what systems might be adaptive at the moment. Maybe it's not a movement system at the moment, but maybe it's in the work progress or it's
Mm.
in a relationship progress, which includes, of course, all other health professionals that are more profound and more professionalized in this part. It might be also something that could be adapted by nutrition. Yeah, so this is, I think, the important thing to open up also to other systems, bodily systems. Not only our body is bioplastic, our
Mm.
bodily systems are bioplastic. And then we can
Mm.
start to change something. And if we think about maybe chaos theoretics or Bayesian models, there might be something going on that back then or further on. This is what I think is very interesting. And to explain this to patients that not to find out the causation of their pain, but the influences that might affect this.
Yeah, that's so interesting. That's so interesting.
Because I
Um,
think this changes. Maybe I have to add this. this changes our way of thinking as movement therapists, as physiotherapists. Okay, our profession is movement. Our profession is, of course, the activity also, especially in Austria, physiotherapists are very keen in and very, very well educated in movement background and sports background as well.
Mm.
But I think it has to open up also when we think about psychologically informed physiotherapy and so on. So this is very important as well, and to include other professions. So
Yeah,
this and we have to be
yeah.
open-minded into this direction. Yeah,
So, I just want to sort of drill down a little bit further
yeah,
into that idea that understanding the barrier can actually be part of the solution. So,
yeah,
how do we actually help our patients to understand and leverage their bioplastic capacity? If you have
yeah,
any real
yeah,
examples, that would be
yeah.
great. We love a real
Self-experience.
example.
I think a very important thing is self-experience, and also one part that we might have lacked of in the last years is to ask the patients about the problem, not only in a clinical reasoning way, like where does it hurt, how does it hurt, but also in what do they understand in their pain, what is their meaning of the pain. And
Mm,
John Loiser also said, okay, to say the actual state, what is their understanding of the situation, but also what cannot be done because of the pain, what has to be done and what cannot be done that I want to do again in their pain situation. So to understand these conflicts the patients often have. And another thing is many people don't know what pain actually means and what it is. And we are so vain to tell our patients how their pain works. And I think this is very dangerous because if we don't ask them what they think about that, and and many of our patients have great, great, great also philosophical ways of
mm,
understanding their pain situation. And this is something where we can jump on this train together with the patients and say, okay, you're very right. This is a good idea.
mm,
Do you want to dive deeper into this topic? Then I can show you more, and then I can show you some aspects where you can try to change and adapt in these little fields. And this could have another effect. I don't promise anything, but this could have. But without understanding the patient and knowing what the patient is thinking about the problem, I think education and knowing about pain and we deliver our knowledge is effortless, actually.
yeah. Yeah. Oh,
Yeah,
okay, that's brilliant.
yeah,
Thank you.
yeah.
We've got a question here from Richmond, and it is, have you considered chronic pain from a trauma immobility perspective and its
Mm,
down regulation through neurogenic movement?
yeah, yeah. Actually, this describes also the plasticity of these systems he described. We have a plasticity going on probably in certain, we don't know in detail, in certain brain regions, in certain spinal regions, probably also that react to brain regions on enhancing or in facilitating nociceptive systems, but also that this is actually a plasticity going on. And if we think
Mm,
about our patients with post-traumatic stress disorders, that always have to be the classic PTSD patients after real big psychological and bodily trauma. But we also have our patients like me at the moment with a knee injury. This is
mm,
also some kind of a psychological stress, and it also affects maybe my bodily systems in some way. Yeah, and uh, I think that this trauma components like an ankle sprain, this is something that has often much more affectation on the person, not only regarding the structure but also in their behavior. Yeah,
mm,
and this includes again plasticity, bioplasticity. Yeah, in both directions. Yeah, in both directions, and can be adapted. I think this knowledge is very important because it leads us to more uh, also immunologically driven, psychoimmunologically driven therapeutic strategies.
mm. Okay,
Yeah,
thank you.
I think it's very
Thank you.
important what I think it was Richmond said.
Yeah.
Yeah.
Yeah, Richmond, thank you for the question, Richmond. That's a great question. We've got a few more coming in here now, and we
Yeah,
will get to as many as we can,
yeah,
but we
let's
may
try.
run out
Yeah.
of time. So thank you, Nina, for saying you're an occupational therapist, and they focus on getting people back to meaningful activities. Do you have any comment on that, Bernhard?
Yeah, actually, we have to find out these meaningful activities. Yeah, these meaningful activities can be completely different to anybody. This is also, I think, sometimes where I really envy also OTs because they have, my opinion here in Austria and in Germany as well, in Switzerland, is that OTs have this, include this social part of the biopsychosocial framework much more. And
Mm,
this is what I really like about that because and I think this is so important also in pain management, in a comprehensive pain management, to include this stuff and meaningful activities have to include our view on social, on the social part, on the social aspects, and which is not that easy because social also could mean my job, and my job is not meaningful to me. So
yeah,
to set it on this could be, but we have to. This is sometimes the harshest part or the hardest part in our pain assessments is what goal do you what's your purpose of rehabilitation? What's your purpose of therapy? What's your purpose of working with me? And this is what I like about John Lewis's question. What is the pain actually stopping you from doing at the moment or in the future, what you would like to do and what you would have to do? And I
mm,
think this is a very important question to ask and to work with patients to get these meaningful activities. And meaningful means completely different to everybody because I
yeah.
think exercise with weight exercising is important because I know the biological issues and so on, but it's not meaningful to everybody. Um,
Thank you.
uh,
Thank you. Thank you for talking around that. It's always a really important point, and thank you
yeah.
for raising that, Nina, because it is something that we do like to emphasize. There's
Mhm.
also a question here from Natibed Dad, Martin. I'm not very good at pronouncing names. I do apologize. And it says, "Do you have an experience in?" Can you see the chat, Bernhard? Are you
Of
looking
course,
at
we
it?
have a look.
In I can't pronounce that either. Sorry.
What was the
Can you see
name?
that?
Natividad Martin
Yeah,
Ortiz.
this one, Natibed.
Ehlers-Danlos syndrome. Yeah, yeah,
Alzheimer's
yeah,
syndrome.
yeah. I can read the question to everybody. Do you have any
Yeah.
experience in Ehlers-Danlos syndrome? It affects many different health specialists and finally produces chronic pain and fatigue, fibromyalgia, and so on. How to go back after 56 years with this system in progress? I'm not a practitioner, but patients in Barcelona. I have followed Neugroup since
Mhm.
neurologists made me discover chronic pain concept. Yeah, actually, Ehlers-Danlos syndrome is, I would say at the moment, and please forgive me if you heard different things, but it's more of a correlation than a causation of leading to pain situations. But we have actually in fibromyalgia, we have it in, interestingly, also chronic fatigue syndrome
Mm,
and myalgic encephalopathy. We have these correlations to Ehlers-Danlos. And of course, Ehlers-Danlos is a structural thing. There are many Ehlers-Danlos patients who don't have pain situations and that don't have chronic fatigue syndrome, but there is a higher correlation, which means, of course, that we have to include this structural component of a more of a bigger laxity of structures, and to be more careful also when we think about vessels here in the part actually in the neck. We have to consider this, but it's more of a correlation, as far as I'm aware of, than a causation leading to fibromyalgia. This is
mm,
what we have at the moment. But it, of course, has to be included because if I think about Ehlers-Danlos as a tissue component, we have to address tissue aspects as well, which means, of course, I have to be aware of how do I train this person. So in this situation, I will get rid of mobility exercises because they don't need it. They need a more strengthening and tissue stiffing even more,
mm.
if this is possible with this genetic background. There's
Thank
also
you.
another one called it's Marfan syndrome. It's similar. Marfan syndrome has a quite interesting also body shape, but there's also correlation to FMS.
Yeah, thank you. That's great. And it's EDS, which is a term I do know.
Yes, Ehlers-Danlos. Yes, yes, yes.
I'm not a clinician, so some of these things do go over my head. And we've got
All
a
right.
great question here from Esther. Have you tried researching the effects of pain education in real time when you are touching the patient, say during a massage, and when you are not? I know what I prefer as a patient and as a therapist. Interesting. Thank you.
Interesting question. Good question.
Good question.
A good question. I have to read it once more. Boom, boom, boom. Do you have any? Wait a minute. It is.
Great questions, by the way.
Have you ever
Brilliant.
tried researching the effects of pain in real time when you are touching the patients during massage and when you are not? Yeah, this is it. I did not research it and I did not do any study of it. I'm actually also not aware of any study, which does not mean that there is one, but we are aware by our experience and clinicians that during um, touching sessions like lymphatic drainages, like massages, like manual techniques, we can use this time
Mm,
either to use these techniques as a sensory training, which I prefer, which I do a lot, so that there is also some kind of sensory training, retraining of how does it feel, where do you feel it, what is the difference between left and right, like Geoff
mm,
Maitland did this many years ago, like how does it feel here, how does it feel here. This is also addressing probably bioplasticity. But it might be also effective if you are in an ongoing like massage or lymphatic drainage technique where you address, of course, also not exclusively, but of course also tissue aspects. You can use educational stuff. I never used I never did the broader pain educational content, but I use nuggets, like we use this term
yeah.
in our explain important courses, short informations, short educational informations that might be helpful, and to try and find out if there is again this great aha moment. Ah, okay, yeah, that makes sense. Like, oh, okay, that's why. And if a patient has question on your education, then he's working with this information. This is always good. If there are any questions regarding your information, then you can be quite sure about the awareness of the patient that there's something going on with this content you just delivered. If he goes out and says, no, nothing, we are not aware of what dropped really the floor of our informational flow we sometimes have. Yeah. And
Mhm.
that's why I use those nuggets during my manual techniques that I still use in a sometimes more specific and sometimes a more not so specific way.
Brilliant. What a great answer. Thank you. I've got one question here that's in the Q&A that
Mhm.
I think would be really great to wrap up with. And it is from Jamie K. And it is, how would you respond to a patient comment in the initial assessment when a patient says, I have permanent back pain?
Mhm.
Great question.
Yeah. First, I want to know what permanent means for the patient. Yeah. And 2 years ago, I would have asked, you also have it in sleep? Yeah. And this might be provoking sometimes because then and the
Mm,
patient says, oh, when I'm asleep, I'm not feeling it. So then you can go on into this perceptual state of pain also. Yeah. But this
mm,
can be very, very provoking. Well, I have to know about what is permanent, and are there any other situations where it is maybe more or less? You can have less but permanent or more and permanent. So I need a deeper knowledge about this what is permanent, if it is always the same. And when I'm working on it and when I'm validating that, of course I understand there is constant pain going on. How is it when you sleep? So it's not permanent then. So
yeah.
because this is might be sometimes you have to be careful with that. Might be a provoking door opener to say, okay, it also is dependent on your perceptual state, where you are in the moment. And that circadian rhythms, like I said before, is plasticity. So there's something changing.
Mm,
Maybe in the morning it is more. Okay, we have another daytime. In the evening it is even more. Yeah, but it is not the same in its behavioral component. Is not the same in its intensity, but it's adaptable, and we have to facilitate. I think we might have to facilitate this adaptive character of pain.
Absolutely brilliant, Bernhard. Thank you. And I would just like to thank everybody for their fantastic questions today. We are not going to have time to get to all of them, but we will be doing more of these live sessions with Bernhard. So please do come along to the next one. And Bernhard, could you just tell? Obviously, we can scratch the surface in one of these half an hour slots, but if you really want to do a deep dive and get fully to grips with this subject area, then Bernhard's Bodily Relearning course is really the place to go. So, Bernhard, could you just talk through people, talk to people a little bit about how what we've talked about today is covered in the course and what people would expect to come away with should they decide to attend the online course with you?
I did this course till now mainly in face-to-face courses, which is quite nice because we have a lot of exercise in this courses. What is the yeah the outline? We of course are going to reflect on current ideas of pain processing, nociception, immunological parts, stress systems. And this is something we focused on, and I saw this in Helsinki. People are still, surprisingly and thankfully, interested in this stuff. And another thing is then to include our other big topic in NOE, which is movement and neurodynamic movement in a more self-experiencing way. And we try to connect these aspects also, which also include, I think, a little bit predictive processing ideas. We had big discussions in our group about that. But actually, it is also something to give our adaptive system new ways, new behavioral ways with movement, which is one of our, in physio, our big components. I think this is something we take out of this course. Another part is that we are working with worksheets, really helpful worksheets that effectively address these purposes of therapy, meaningful activities, meaningful situations in your life, barriers and resources. So we in Explain Pain, we have the so-called protectometer, which is, I think, a quite nice tool, but it doesn't fit for everybody. And Ben developed a very nice model also with worksheets with barriers and resources addressing the psychoneuroimmunological system, which means the bioplasticity in our bodily systems. So I think this is something we can really benefit out of this course. I also benefited a lot when I teach it the first time. So, yeah, okay, this is a really nice worksheet Ben has there. Yeah, but we are now I'm translating it culturally and in language, and yeah, this is what we are going to talk about.
So,
Yeah, Ben Boyd is the creator of this course.
Yeah.
He also wrote a very nice book, and I think it is it fits perfectly when you've already done Explain Pain or did other pain courses. It fits perfectly with that. It is fun because we include movement, where I was very surprised that in Finland, actually, the therapists were very keen to these movement components. Which I did not expect because I know myself how I behave in a course, and but it was really nice to work with them in this new ideas, which might be known by some, but which might also be new to other ones.
That's brilliant. Thank you, Bernhard. I think the course is very practical. It is one of our newest courses and draws in on so many elements of other courses that people may have done. So just a quick question here from Nina. Are the exercises taught suitable for someone from an OT background to learn and teach patients?
In the Bodily Relearning course? Yeah. Yeah,
Yeah,
I think it is like in Explain Pain or also the neurodynamic courses, of course, okay, there are then some techniques for the lower body parts, but I don't make a difference into that. I'm happy to have as many different professions in a course because every course really benefits from different views. Okay, we have this when there are no only physios, of course, as well, but OTs, psychologists, psychotherapists. They had one course with a psychotherapist in a course. This was great. Yeah.
yeah,
Exercise trainers. So I'm very happy to have as much professions as there are, because there are a lot of people working with patients in pain.
yeah,
And sometimes we say in Austria, everybody's cooking its own soup. Yeah. And this
yeah,
tastes nice, but I think it can get even richer and more flavorable with more ideas.
yeah. That's brilliant. Thank you so much. Thank you, Bernhard, for that. I have thoroughly enjoyed today's conversation, learnt loads as always. And thank you to our audience. You've given us some fantastic questions today, and
Yes,
it's
great.
taken us in a lovely direction and given us the opportunity to introduce you to the Bodily Relearning course as well that Bernhard's presenting in October. Check it out on the website. We have a previous clinical discussion that we did with Bernhard that he referred to here. Go and check that out on the Clinical Discussion YouTube channel and watch out for the next one because we've got at least one more coming up soon. So thanks, everybody. Enjoy the rest of your day,
Thank you
your
so much.
evening, and we look forward to seeing you again. Thank you. Take
Enjoy the
care.
summer or the
Enjoy
winter
your
on the other
summer.
side of the earth.
Yeah.
Bye.
Thank you. Bye bye.
Bye bye.